Well, thanks, JC. Hopefully, everybody got to meet some new folks there and connect. But with that, I'm going to turn it over to Hannah for the next 10 minutes to share what she's working on. And feel free to put any questions for her in the chat.
Sweet. Can everyone hear me all right and see my screen?
Yes.
Perfect. Well, good morning, everyone. I'm super excited to be here. It's my first time coming to an Atlanta Ventures event. So even beyond the health tech meetups, it's my first ATL Ventures event. So very excited to be here. I'm tuning in from St. Louis right now. I'm here for a speech this afternoon. So I am in a random hotel room. So apologies for my blurred background. But super excited to connect. I'm the co-founder and CEO of a company called Disclo, short for disclosure, which we'll get to today. And I'm excited to connect with the healthcare group because I'm usually in rooms with HR, and we really do work at the intersection of health and employment. So it's nice to kind of branch out of my normal comfort zone of the human resources world. When we started our business, our belief was really simple, which was that disclosure is really the hardest part of work, especially when health is involved. And we knew kind of from day one that the hardest and messiest, most avoided part of wasn't really workflows or forms, it was medical proof and eligibility. Because I think once health really kind of enters the workplace, everything changes. Liability changes and risk changes and power dynamics change as well. And what we found is that the system that's underneath that moment is surprisingly really fragile. And so we didn't start in the health verification space, actually. We started by building the system of record for workplace accommodations. For those of you who aren't familiar, workplace accommodations apply to folks who have a qualified disability under the Americans with Disabilities Act. It is the most complex and litigated employment workflow in HR today. And so our platform manages that end-to-end accommodations process all the way from the intake to the resolution and maintenance of someone's accommodation. And we sit at this really interesting place where we're at the decision layer where medical information becomes defensible employment outcomes. And we're lucky that companies like Panera and Clear and Reddit and all these awesome brands today now trust us with these really high risk employment decisions. And, through processing thousands of medical cases within our own product, we landed upon something much bigger, which surprisingly enough, we announced yesterday. So I'm going to be talking about that for the next few minutes here. But every year in the United States, employers are manually processing about 40 million medical verifications, which means that 40 million times a year, a manager or an HR team or a vendor is receiving a doctor's note from an employee and has to decide, is it sufficient? Is it complete? Is it legally compliant? And what does it entitle the employee to? And this is outside of just the world of accommodations. This is for leave. So if you've ever gone on parental leave or a medical leave of some sort, it's pregnancy protections, workers' comp, short-term and long-term disability. It happens pretty much every single time that health intersects with an employment law. But until now, there's really been no standardized way to interpret and audit and apply that proof across all the different systems. So there's, tens of millions of employment or high liability decisions that are being processed manually and being interpreted differently every single time. And so what we see is that this isn't just an HR workflow problem, it's really a compliance infrastructure gap that we saw that hiding really in plain sight. Pardon me, I'm already losing my voice and I've got a presentation later, so I'm going to take a sip of water. Bear with me one second. Um, and so what's happening actually on the ground is that medical providers are sending back unstructured documentation to employers, and paperwork doesn't meet different state standards. There's manual follow-ups that are happening, and they can drag on for weeks, if not months. And there's legal exposure, unfortunately, at every single step, which, by the way, disability discrimination is the number one cause of lawsuits for companies. So the bottleneck really here wasn't about reading documents. That's something we could always do. As we know, there's lots of cool AI tools out there that can do that. What the real problem is standardization and governance and auditability across all the different systems. And that's where AI really helped us to unlock scale. And that's why we decided to build Disclo Verify, which again, we just announced yesterday. So this past quarter, we took a piece of our accommodations product and shipped it as a standalone embeddable tool, which we call Disclo Verify. And it's got a configurable rule engine, and so any employer or vendor can integrate with the platform as a medical verification layer for almost any policy that requires med certs. So that could be again leave, accommodations, disability, return to work. This could apply to the education sector as well. And we do have humans in the loop on every single case, so we're also making sure to verify provider credentials, cross-checking MPI numbers, validating specialty relevance, and really helping to produce structured decisions with very clear rationale. This is a if you zoom out, this is a pattern that's happened before in pretty much every single high volume, high liability category with fragmented workflows. It eventually gets replaced by infrastructure. And I think we've seen this, one of the best examples, a background check. And so medical verification really is the same kind of category here, but unlike a background check, which happens once at hiring, this actually happens across the employment life cycle. And so the volume's a lot higher. There's a lot more recurrence and the liability is a lot greater because we are interfacing with medical documentation. And so it makes it not just another HR workflow, but really an employment-wide infrastructure play. And we really think that medical eligibility is the next category to go through this change that you see on this screen. It's a category where team matters a lot because we're sitting at the intersection of employment law, healthcare, data privacy, enterprise software, and mistakes carry very real legal and human consequences. And so we've spent years operating inside the most regulated parts of employment, and hopefully we're the team to do this. We've pulled together an amazing team from the product side to go-to-market operations. And it's really, this isn't a team experimenting with compliance. It's a team that is built for it. Um, so that's what I've got. I'm happy to answer any questions. I think, a few years ago, we set out to make disclosure safe at work. And we are still on that mission to do so. And I think just right now in a really exciting stage of getting to expand and move deeper into the ecosystem. So very excited to connect with all of you and happy to answer any questions.
Great. Thanks, Hannah. Folks, if you have questions, put them in the chat. We'll try and call out a few, but just one to start, Hannah. As you mentioned, the different regulations at the federal level, at the state level, at the company level of how to do things. How much variance do you see across those? Like, is each customer a custom set of things, or are there standard things that go across all customers?
It's a good question because it should in theory be standardized, but every employer has their own forms and there's state forms and all of these forms are changing constantly and updating. And so it's quite complex. And I think COVID really changed this space in general. What back in the day we were verifying, typically a disability request was related to some type of physical limitation. But living, in the post-COVID era, we're seeing more and more chronic health conditions, mental health struggles, and those are a lot more challenging to verify and to get to the bottom of, and especially with all these kind of overlapping regulations. So all that to say, it should be standardized, but and standard, but it is not.
Yeah. Well, great. Well, I'll do one more question from the chat, and there's a couple others, Hannah, I'll let you look at and answer there. Who's the ideal customer size and how does pricing work?
Yeah, so for our core platform, our accommodations product that we've been selling for the last 3 years, typically, as you may have seen some of the logos on our screen, we have moved up market. And so typically we're working with companies with a minimum of 5,000 employees, but we do go as low as about 1,000. But in terms of ICP, it's really an interesting thing because we had assumptions that this would be companies that are, forward thinking and wanting to build inclusive benefits plans. But the reality is it's typically high volume workplaces. So a lot of, manufacturing, where we've got people who are on their feet. So a lot of healthcare systems. That's where we just see a higher volume of people disclosing and needing support. And pricing, we charge for our core product based on the size of the organization. So it's an annual fee that typically we're selling 50 to 150K contracts. The pricing for Verify is very different because it's much more like a background check where you're buying packages of med certs and being able to utilize those and then kind of re-up on those packages, which makes it a lot more flexible and dynamic and allows us to kind of just enter in without a massive contract off the bat. A lot more approachable.
Awesome. Well, Hannah, great. Well, thanks so much. Love what you're doing. There's a couple other questions in the chat if you want to check
Cool.
those out. But with that, I'll ask Amari to join us to share what he's working on.
Cool. Thank you so much.
Thanks, Hannah.
Awesome. Hi guys. There's Amari. Let me go ahead and do a little share of my screen. Let's see. Ding ding ding. Okie dokie. But yeah, again, my name is Amari, and I'm the CEO and founder of Greater Change. We are, well, at least I like to say that we are the most on-demand and affordable mental health care platform on the planet right now. We're gonna loop back around exactly to what we do, how we do it, and how we're so, again, on-demand and affordable at the same time. But I guess a little bit more about myself because I feel like it ties into the whole thing. But I started my company when I was an undergrad at Emory. I went to Emory down here in Atlanta. I don't have to explain that. I feel like it's nice because it's you guys are also from Atlanta. But originally I was going into neuroscience. So I was going to go to med school, be a surgeon, but I got really depressed towards the end of my college career. I went to college in 2020. So at the peak of COVID, there was like 10 and a half people on campus in total. And things didn't start to become a little bit more normal until the end of college. And that's when my depression got as bad as it did. I didn't want to go to classes. I didn't want to go to work. And the college itself didn't really have the mental health services or the care that the students should have been afforded. And with me being in college, paying for my own car, my bills, and things like that, I couldn't afford a $200 session every single week, and that inspired me at least to switch my major to psychology and learn a little bit about myself. And with that, switched to psychology. Soon after, started the company Greater Change. We started as a smaller private practice adjacent thing where we're just connecting people that were looking for a therapist to a therapist. And then we got to the point where we had so many people looking for therapists that we started to hire more therapists. And we got to a point where we had so many therapists that we could go into enterprise things. We could go to a Emory or I don't know, a Zaxby's and provide our services to their students or their staff. And the company we've been up and running for about a year and a half, maybe 2 years, but we've been operating the way that we have for about 10 months because I went and started my master's about 10 or so months ago in marriage and family therapy. And from there, I feel like we were able to really launch because once I got to my master's in marriage and family therapy, I learned a lot is wrong with our industry. So I guess I'll go backwards now and explain what Greater Change is and how we do it and how we're so unique. So Greater Change, you can go on, you can subscribe on the direct to consumer end, and we afford you a therapist instantly. You can always hop on the phone and speak to a therapist. You can text on the platform and speak to a therapist. And then as well, you can schedule a virtual session, kind of like a Zoom, like we are right now. And we have those therapists 24/7 around the clock every day of the year. And we're able to do that because when I got to my master's, I realized that practicum level workers for therapy, psychiatry, etc., are not usually paid. It's really bad. They have to get 20 to 30 hours of clinical work every single week, but they are not really paid for it. So we decided to pay them. One, because I wanted to be paid when I was doing my internships, and as well to get people that care quickly. I don't know how much you guys know about the mental health or insurance landscape. I was talking about it with Jackie in my breakout group, but only around 30 or so, some odd percent of therapists, psychiatrists, and psychologists actually take insurance in practice. It might be a little bit higher, something like 40 or 50%, but in practice, when you account for people that don't have entirely full caseloads, only 30% of mental health care workers take insurance, which leads to super long wait times. So the consumer, you guys, are left with a choice of pay $300 a week or wait 3 months to be seen. And because we have such a large volume of therapists and practicum workers that can see clients at any given time, it allows us to have people be seen instantly as soon as they log on. And that's also allows us to charge significantly less than a You Will or a BetterHelp or a Talkspace adjacent, if that makes sense. So we've made quite a bit of traction in the little bit of time that we've existed. So we have about what, seven or so? Yeah, seven B2B contracts right now with both employers and schools, and a little bit on the ICP. So right now we can't take on a UGA or an Emory with 15 plus thousand students, but we're targeting those niche SCADs or LCADs of the US with around five or so thousand students. We can go in and be that mental health provider both on campus and virtually. I say on campus because I don't know how much you guys know about the EAP and student adjacent landscape, but I'm sure Hannah knows. Usually EAPs are not used. We get on campus and we make it part of both company and student culture. So that one boosts our utilization way up, and it also makes us get renewed when that renewal time comes. But multiple B2B contracts in terms of clients served between B2B and direct to consumer subscribers is about 4,000 right now. Then we just recently closed on an angel round in February. My co-founder's in here somewhere. He can correct me if I'm wrong. And then as well, we're just hitting 200K ARR, and we're looking for another raise at the end of the year. But a little bit about our team. So me, I have multiple degrees in say psychology, so psych, and then psychology slash marriage and family therapy is my master's. Our co-founder Tim, he's in here somewhere. He's been running a marketing agency since he was in like high school. But he's helped scale ventures like mine in the past, and we brought him on. I actually met him at the park, but our advisory board is really, really stacked. I met a lot of them at Emory through their accelerator program, but between all of them, they've exited with more than $3 billion in company profits. Alyssa exited not too long ago. Barry, he's running a pharmaceutical company. He's also exiting within the next 12 or so months. And yeah, that's a little bit about me and greater change and no, me again. But do you guys have any questions so far?
Great. Thanks, Amari, and appreciate you tackling such a real problem that goes underserved for a lot of the reasons that you described. Again, put questions for Amari in the chat. But I have a question just to start. You mentioned, hey, I think you said seven B2B customers, but also starting, kind of direct to consumer and stuff. How do you think about the balance of going sort of more B2B versus going
Yeah.
to consumers?
Yeah, so I actually had a conversation with another founder of a similar company called Social RX. They're a mental health adjacent company that does something similar, but they prescribe like Pilates and physical activity things. But essentially, the sales cycles for these are for B2B is specifically with schools and employers can get really, really long. Like Emory, their previous contract with a competitor was for 10 years, so the direct to consumer piece helps mitigate that, helps give us a bit more runway. Then as well, that's kind of how we started. That's kind of, so I'll be honest, that's something that we're reevaluating as this year goes on with us raising again. We started direct to consumer and we had such a big volume of people that were willing to pay. And we used that to scale to B2B to tackle those bigger contracts and build out that infrastructure. So it worked in the past, but it's kind of something we're reevaluating now to answer your question.
Awesome. One thing to check out, just going back in the archives of healthcare meetups, we had two companies called Motivo and Informed that we had interviewed back,
Mhm.
I think the first
Oh
year we did
yeah.
it, and then we did a recap with them, I think last year or the year before. But they both talked about that transition from starting B2C, getting some really
Mhm.
customers, but realizing that was going to be hard to sustain in the long run and sort of switch to B2B.
Absolutely.
So that may be an interesting one to listen to. It's on our website if you
Yeah.
could.
I love to. Actually, I know the Informed founder. I think we met him at he
Geesh.
was
Yeah.
yeah, he was at the lunch with us. Yeah.
Great. Great. Well, cool. Well, there's some other questions in the chat. Omari, I'll let you jump to those. But
Awesome.
thanks for sharing. And with that, I'll ask Andrew to join.
Yes, let me share my screen. Awesome. Can you guys see that?
Yes.
So I started Qatalyst Health close to 2 years ago. We help nursing homes with a variety of tasks from the second they get a referral from the hospital all the way through the patient's journey. And close to 2 years ago, I had a brief conversation with the nursing home administrator, kind of randomly, and started digging in more and talking with the rest of his staff on a more extended basis, and basically saw how much data that all of these different teams across nursing homes have to read and analyze. And one missed data point here or one missed sentence that you did not flag could mean both like worse care for the patients, but also significant reimbursement dollars left on the table. And a lot of times these staff that were nurses, they went to school to take care of patients, were sitting behind the computer reading all of this information as opposed to spending time with patients. And I think like half the nursing homes in this country are operating on sub 1% profit margins. So everyone's strained, the margins are strained, and there's just way too much information that needs to be analyzed to make sure that these facilities both remain profitable and that the nurses can actually spend time at the bedside. So there's kind of three core steps along the patient journey that we impact: pre-admission, the reimbursement process, and then the clinical team, and as the patient's care changes once they're in the building. On that pre-admission side, take like Grady Hospital in downtown Atlanta, for example. They're sending out referrals to every single nursing home in the geographical metro Atlanta area. And those referral packets are often like 100, 200. We've seen some that are 400, 500 pages long. And it's just unstructured data that this admissions coordinator has to read. They usually get like 10 to 15 minutes to respond. And if they miss one thing, the patient shows up, they learn that the patient's on a trach and they can't take trach patients. They have to send the patient back to the hospital and determine the clinical fit within those 15 minutes, the medications cost, and just a whole host of other information. And once the patient's actually in the building, the reimbursement team has to read through these same documents to flag any reimbursement opportunities, ICD-10 codes, and complete their initial set of reimbursements. And so if you're having to read 300 pages worth of medical documentation, odds are you are going to like miss something on page 167. And then as the patient's actually in the building and receiving care, the average patient gets about 30 to 40 new data points a day going into their clinical chart. And so if a nursing home has 100 patients, so that's like 3,000 to 4,000 different new data points each day that have to be analyzed correctly to make sure that your reimbursement stays proper and updated, and also that that patient's care plan doesn't need to be changed so that they can get the best care possible. So at the high level, what we do is we read all this information at every step along the journey and allow the staff to make much greater informed decisions much faster. So we can ingest that referral and tell them everything they need to know to make that admissions decision, usually in about 5 minutes. So we'll tell them every single active medication and its costs, the patient's insurance eligibility, and we can do a custom clinical and health analysis because each facility is a little bit different in what they can and can't take. Usually we see on that side are around $10,000 a month in reduced medication savings because we're able to flag like generics versus on brands for them, and a handful of other different things with medications, and allow them to respond way faster. And then on the reimbursement side, we read those same documents again, and we'll inline highlight all of the coding opportunities and billable services for them so they can get paid for 100% of the services they provide. It ends up, we usually see their rates go up about $25 a day, and that their probability of misbilling also goes significantly down. And then on the clinical side, we integrate with their EHRs and read all of those ongoing 3,000 to 4,000 new data points a day. And we'll flag reimbursement changes for those reimbursement teams, as well as any clinical declines that could impact both the patient's health and their quality measure scores, which is just Medicaid's scoring system for how they score how well a facility gives care to its patients. So on that side, it's greatly improved care and reduced citation risk for the facility. We're in about 15% of the facilities in South Carolina and starting to expand here into Georgia pretty quickly, and then some out on the West Coast as well. But that's what Qatalyst Health does.
All right. Thanks, Andrew. As you're going through, a couple of these, what we do's, can you talk more about how they think about the value prop of, do they care more about the hey, the revenue, sales, and marketing side of bringing people in and the right people faster? Do they care more about the reimbursement dollars just by coding properly, or do they care more about the right care, which allows them to avoid lawsuits or staffing appropriately, things like that? How do they think about which is more important of those three areas?
Yeah, I would say it varies building to building. Like, say we come in and talk to a facility that just got a multi-$100,000 fine because they had the patient's code status as do not resuscitate when it was actually full code, then they care about our clinical side way more. So it just depends where the building's at. I will say there is, in general, the admissions and referral management side does hit home very consistently with everyone. Some buildings think they have like great MDS teams that are able to find all the reimbursement dollars. So it just depends. Admissions is pretty central though across everyone, because everyone's had the example usually in the past couple of months where they accepted a patient, the patient shows up, and then they realize that they can't take care of that patient properly, and they have to send the patient back to the hospital. So everyone has those consistent stories, but it just kind of varies building to building.
Got it. And then do you see any trends, regionally or by size of facility that affect kind of your value prop?
Yes. So sometimes I think I'd probably say about 20% of the time, once you cross 10 facility operator, so a chain that's operating 10 buildings, sometimes they've centralized some of these roles. So the value proposition is just different for them. It's making that central team way more faster. So they may have, 4 centralized admissions coordinators as opposed to one at every single building. So the value prop just switches a little bit for that. Does that answer your question?
Yeah.
Yeah.
I think a question from the chat here about going state by state. Does the software need to be adjusted for each state, or is it more focused sales and operations efforts?
Yeah, so the only thing that changes statewide is the Medicaid reimbursement patients specifically, which usually is about half the patients in the building are on Medicaid as opposed to Medicare or some sort of managed care. About half of the states, though, on the Medicaid side, adopted Medicare's reimbursement model. So for those states, like we're all good. For some of the other states, usually it's like your smaller states have some bespoke reimbursement calculations on the Medicaid side. So we have to tweak it some around how we flag that, but we built the software to be pretty modular. If we are going into a new state that has not adopted Medicare's reimbursement structure for Medicaid specifically, it usually takes us about a week to get the new rules adjusted into our system and live.
Got it. Got it. Well, cool. Well, thanks, Andrew, for sharing. As we come to the end, I'll be to stay on here, Andrew, and I'll ask Amari and Hannah to rejoin us here if you're still around. And, one of the things we always like to do is just kind of go through at the end and, let you guys pitch to us of like, hey, what are you looking for in terms of, roles to hire or types of customers to talk to or find or investors to look for? So Andrew, I'll let you sort of, go first. What are the things that we can do as an audience to help you with where you're at?
Yeah, so I think in the next couple of months, we're going to be hiring our first sales and customer success people. So if you have anyone in your network who's like a true 10 out of 10 person in either of those roles, I'd love to talk to them.
Very good. Well, one thing there, Andrew, I'd say through like Atlanta Tech Village, other places, there's lots of startups and folks in those roles. And as some startups, for whatever reason, may or may not keep moving forward, there's a lot of good folks that are often around that could be good fits. So,
yeah. And Andrew, my one piece of advice is make sure that you all have nailed founder-driven sales first and understand a sales process, because I think a lot of companies, including us, made the mistake of hiring for sales too early. And then, you kick yourselves after. It's like you can't expect someone else to sell your product when you can't yet. So I think that's one piece of advice on the sales front.
Yeah. Thank you.
100%, Hannah. We see that all the time, right? So like, because then if you haven't done it yourself, if it doesn't work, you don't know, is it because the process wasn't there? Is it because the salesperson wasn't right? Is it versus when you do it yourself, it can work. And now it's finding the right people in the process.
Yeah. I don't know if there's a different mental framework you guys would suggest, but the one I've been kind of using in my head is if it feels like kind of robotic, that's probably when we should bring someone else in. Like if I stop learning new things in our sales process and I know the answers to the 10 questions anyone could ask, and then it's pretty easy to like boilerplate it and grow it out from there. I don't know if there's a different framework you guys use though. If you're thinking about that.
Yeah, I'm happy to chat
Talk.
offline too
Okay,
as
cool.
well. Yeah.
Yeah, no, good topics there. Great. Thanks, Andrew. Amari, you want to kind of share anything you're looking for that the audience can help you with?
Yeah. I guess number one would be just feedback. If any of you guys want to let me run my ideas, but yeah, that'd be my number one thing. I feel like having someone to speak to is just number one for me in general. But aside from that, if you guys know any deans of any college or any professors even for any of the colleges in the Southeast area, that'd be super lovely, an intro to them in terms of ICP for schools. Any schools with roughly around 5 or so thousand students. For those bigger schools like Emory and Georgia Tech, we're running pilots with them for their business schools respectively for that number, not the entire campus, but that'd be super helpful. And in terms of employers, around, employer sizes of around 100 to 500 is kind of what we're trying to standardize for right now. So if you know any of those people, shoot me an intro. And operations, already spoke to someone in my breakout room group, but our next big hire is going to be operations, getting me out of the everyday. So if you guys know anyone in terms of that, that'd be super helpful.
Great. Thanks, Amari. Hannah, anything for the group that we can help with?
I'm raising a seed extension round, which is tricky, just because it's an awkward round. But we were about to go out for our A and decided we wanted to make sure that we really nailed our go-to-market for our new product before doing that. So we're working with our current investors, but looking to try to get some more kind of strategic healthcare focused investors on the table for this. So if anyone knows any cool funds that are in the health tech or insure tech place or space, please let me know. But otherwise, I'm also always
How much are you raising, Hannah? Just for context.
I think we're probably targeting, in the 1 to 1.5 range. We've raised like just over 6.5 to date. So, but it's been a few years now. So, this is kind of the not fr coming from a place of we need it, more so it's really an accelerant to try to get us to a really nice A versus, a half baked A.
Yeah. No, very good. Very good. Awesome. Well, thank you all for joining today and sharing their stories. Always cool to see some of the latest things that people are working on. That's I think what's unique about healthcare is right. 3 different founders, 3 different spaces, but all doing cool things that can have an impact. So as we wrap up, just want to remind folks we've got a bunch of resources online. So if you go to atlantiventures.com/healthcare, you can view all of our past meetups, like the one I mentioned, Amari with Ashish from Infarm and Rachel from Motivo, talking about B2C to B2B transition. There's plenty of good ones on there to check out with recaps as well as the full recordings, and we'll post these and share those on there as well. If you're a healthcare company and want to be listed, there's a form to fill out and we'll add you to websites. I get asked all the time when people come by, hey, who are some healthcare companies in Atlanta or where? Fill out the form and we'll add your name to the website as well, because that's something we send to folks a lot. And then upcoming events. Today, Catherine's doing some great stuff at the Women in Tech Meetup here at Atlanta Tech Village. Thursday, we have our monthly, there's Catherine. Thursday, we have our monthly office hours event. So every month, Catherine, JC, myself, just do virtual office hours. Feel free to jump on, ask any questions, whatever the topic you want. We'll try and answer those. And then upcoming healthcare entrepreneur meetups. We'll do one this summer, TBD be a virtual one. So probably June, July timeframe. And then we've got locked in early September. Kristen from Stat Wellness here in Atlanta, we're going to do an in-person healthcare entrepreneur meetup combined with Women in Tech. So those are some of the upcoming events we got going on. Wrapping up here as we're close to the end of the hour, but thank you again, Hannah, Amari, and Andrew, for sharing what you're working on. Hopefully folks can connect with them and help support them in what they're doing. And thank you everybody else for joining, and have a great rest of your day. Take care.
Oh, AT also.
Yeah.
We're doing something similar with Right Shift and a VC called Renew Capital, but I love to talk to you, get you on this the calendar sometime to talk
Yeah,
about
yeah. Send me an
us.
email. We'll find time.
Awesome. Good man. See ya.
Thanks,
All right,
y'all.
take
Have a
care.
great time. We'll see you guys at the next
Bye.
one.